I last left off addressing the claim that the therapist is better equipped than your friends, family, or loved ones to treat you with empathy. When used to socialize the client into therapy, this kind of approach can lead to harm. Moreover, therapy is not just about empathy. For example, the most popular therapeutic system, cognitive behavioral therapy, as I uncovered in an initial look, is designed to challenge negative thoughts and dysfunctional beliefs and change behavioral patterns. In other words, if the therapist adheres to this system with you as a client, he or she will treat your thoughts, feelings, and behaviors as a problem needing to be fixed rather than as a difficulty to be treated with warmth and understanding. But empathetic or not, CBT deserves a closer look. And here again, I will pull from scholarly articles. To first try and conveniently sum it all up, however, researchers present CBT as being the most empirically based form of therapy in existence, even though the studies that support it are often weak or low quality. Furthermore, when the cognitive components of CBT are studied separately, the results undermine the idea that thoughts must be challenged in therapy. And lastly, by being fixed on problems in the here and now, CBT may also ignore a client's broader underlying difficulties. And I will start with the article Cognitive Behavioral Therapies, Achievements and Challenges by Brandon A. Gaudiano, Ph.D. from the Department of Psychiatry and Human Behavior, the Warren Alpert Medical School of Brown University, and the Psychosocial Research Program, Butler Hospital. CBT as an increasingly popular and evidence-based practice. CBT has become increasingly popular with clients and the general public alike over recent years. Surveys of therapists indicate that CBT is fast becoming the major orientation of practicing psychologists. Partly because of its common sense and clear principles, self-help books based on CBT approaches also have come to dominate the market. Even media articles frequently extol the virtues of this form of psychotherapy. A recent Washington Post article proclaimed, "For better or worse, cognitive therapy is fast becoming what people mean when they say they are getting therapy." What accounts for CBT's sustained and growing popularity? The short-term, structured nature of the treatment made it particularly amenable to empirical investigation, and it has accumulated an impressive research base. One set of researchers, Butler et al., report that there are now over 325 clinical trials of CBT for various clinical populations, including mood disorders, anxiety disorders, marital distress, anger, childhood disorders, and chronic pain. In their examination of 16 separate meta-analyses of CBT studies for a variety of conditions, Butler et al. Reported that the treatment produced large effect size improvements compared to control conditions for emotional disorders in adults and adolescents. And more on this important set of claims later. Furthermore, results indicated that CBT was somewhat superior to antidepressants and equal in efficacy to behavior therapy in treating adult depression. In recent years, CBT has even been shown to be an effective treatment when added to medications for patients with schizophrenia. Because of this impressive amount of empirical support, it is not surprising that CBT has found its way onto most treatment guidelines for a variety of psychiatric conditions. By its very nature, CBT can be easily disseminated and implemented than other approaches because of the development of highly specified, manualized treatment protocols designed to be delivered over short-term durations. Given these factors, it is predictable that CBT has become a favorite choice by managed care companies in the U.S. looking for cost-effective alternatives to traditional psychotherapy. Similarly, this can be compared to what the authors of What Do Psychotherapists Really Do in Practice note regarding insurance panels requiring providers to offer CBT, as I have previously highlighted. What is CBT? The CBT model proposes that psychopathology is the product of faulty information processing that manifests itself in distorted and dysfunctional thinking, which directly leads to negative emotions and maladaptive behaviors. Thus, the CBT therapist helps the patient to identify, evaluate, and then modify distorted cognitions to produce more realistic and adaptive evaluations. It is assumed that correcting patients' distorted cognitions in this manner will produce direct improvement in both mood, for example, the patient will feel less anxious, and behavior, for example, the patient will perform better at work and be more social around coworkers. Although the cognitive techniques tend to be emphasized, CBT also incorporates a variety of other behavioral strategies, including activity scheduling for depression and exposure to feared stimuli for anxiety. Criticisms of traditional CBT. Given the dominance of CBT in certain settings, it is not surprising that the approach has garnered its fair share of critics. Opponents have frequently argued that the approach is too mechanistic and fails to address the concerns of the whole patient. However, in recent years, some of the most pointed criticisms have emerged from within the CBT community itself. First, the specific cognitive components of CBT often fail to outperform stripped-down versions of the treatment that contain only the more basic behavioral strategies. This insight comes from a special type of treatment research called component analyses or dismantling studies, in which the specific components of CBT are experimentally manipulated. And I will look at this criticism in a separate article. Do We Need to Challenge Thoughts in Cognitive Behavioral Therapy by Richard J. Longmore and Michael Worrell from the United Kingdom, published in Clinical Psychology Review in 2007. As the authors write, this paper has attempted an empirical rather than a theoretical examination of the status of cognitive interventions in CBT. A comprehensive review of component research into the active elements of CBT was undertaken. This examined studies both of depression and the anxiety disorders. The review showed that, almost without exception, component studies found no difference in effectiveness between the cognitive and behavioral elements of CBT. Nor did cognitive interventions provide added value to behavioral interventions. Taken together, these studies provide a substantial body of research showing that cognitive interventions are not a necessary component of the therapy. The issue of cognitive mediation was then examined. If, as Clark asserts, CBT works by modifying dysfunctional cognitions and realigning thinking with reality, then it should be possible to show cognitive change mediating symptomatic improvement over the course of therapy. Evidence pertaining to this hypothesis was reviewed. It was shown that there is currently little empirical support for cognitive mediation. Taken together, these findings reveal a worrying lack of empirical support for some of the fundamental tenets of CBT. There is a paucity of evidence that cognitive interventions forming the core procedural aspects of CBT are differentially effective in reducing distress. Further, there's a lack of evidence that their effectiveness, such as it is mediated cognitively. Given this state of affairs, it is somewhat surprising that there is not more research on these issues. In short, the cognitive components of CBT, which target negative thoughts and underlying beliefs, may lack empirical support. Continuing from Cognitive Behavioral Therapies, Achievements and Challenges, and the section Criticism of Traditional CBT. CBT has lacked a strong link to cognitive psychology and neuroscience, or at least until very recently. Even though CBT was being formally codified in the 1970s, when experimental cognitive psychology was also emerging as an important new science, CBT developed primarily from clinical observations obtained in the therapy office instead of the laboratory. Thus, the theoretical basis of CBT was not well connected to the emerging science of human cognition. This has resulted in the need to modify central aspects of CBT theory over the years to better conform to the experimental knowledge being accumulated by cognitive scientists. Although at least some effort has been made to merge other systems with CBT, the problem is that, based on all appearances, no attempt has been made to modify CBT itself, much less its central aspects related to human cognition. And in my next video, I will jump right back into the idea that CBT studies produce large effect size improvements compared to control conditions for emotional disorders in adults and adolescents. I hope to see you there.